I'm going to be presenting my audit, which I had done on the TMACS decision aid for for assessing patients who present to ED with chest pain. So what is the TMACS decision aid? The TMACS aid is a tool that uses a computer model that helps us to rule in and rule out ACS, basically using a combination of 6 clinical features and one biomarker, which is troponin. Has different components, very easy to use. You can use ECG, ischemia, worsening crescendo angina, whether there is pain radiating to the right arm or shoulder, pain associated with vomiting, any sweating that was observed, and hypotension on arrival, and troponin levels on arrival. Now, based on these readings, we get a risk stratification, whether the patient is a low risk, moderate risk, or high risk, and accordingly we can have different advices. Now, these advices will vary based on different hospitals who have different setups and different dynamics. However, for a low risk patient, generally it is that we can repeat the troponin in 3 hours in ED itself, and the patient can be discharged without being admitted to hospital for further testing. However, the patient is highlighted as a moderate risk or a high risk patient, then the patient can be admitted whether to acute medicine or directly to cardiology. And we can do a repeat troponin before sending the patient home or taking the investigations further. Now, there are different advantages of using this TMAX tool. The most important one being that it can highlight the very low risk patients, the low risk patients who can be a candidate for direct discharge from ED, and thus this will help us in preventing the unnecessary admissions, which will help to conserve resources and provide a better patient experience. The other thing is, instead of using multiple biomarkers, we are just using single biomarker, which helps us to conserve resources. It also highlights the moderate risk and the high risk patients in ED itself, which can be which enhances safe practice and lessens the probability of missing ACS. Also enables a more comprehensive referral from ED and helps the accepting clinician to have a better understanding of the patient by knowing the risk group, and also enables faster and smooth ED patient flow. Now, various statistics that helps the TMAX tool has a very high negative predictive value, 99.3%, with a sensitivity for ACS 98.7%. And it has also been found that it is able to rule out ACS in 40% of the patients, while ruling in about 5% of the patients at the highest risk. Now, making its comparison to other scores, it has been found that, as explained earlier as well, the TMAX score has been shown to be more accurate than the HEART score as well as the TIMI score in predicting these low risk, high risk, and anticipated 1 month risk patients for MACE, and has also been found superior to the MACS tool. Whereas MACS highlighted only 10% patients, while TMAX highlighted about 20% patients as very low risk, thus facilitating more early discharges. Now, the audit was conducted in Manchester across 3 hospital sites. A total of 300 patients were taken, about 100 patients from MRI, Wythenshawe, and North Manchester hospitals, and data was collected randomly across a 2-month period of 1st November 2023 to 31st December 2023 retrospectively. We included all the patients who presented to ED with a chief complaint of chest pain, however, excluded anyone who presented with a non-cardiac or a pleuritic chest pain. Also, patients who were being admitted for an alternate diagnosis or when ACS was not part of the primary differentials were also excluded. So the kind of data that we collected was, we collected whether the ED clinicians used the TMAX rule in those selected patients and what impact they had on the disposition, whether the patient got admitted or discharged, and whether the ultimate diagnosis of ACS was reached, and what was the overall length of stay for these patients in the hospital. Different set of data was reviewed, including the ED clinician notes, the admission note, the post-acute note, and even cardiology whenever they were consulted. So the audit results found that it was the MRI hospital which had been using the TMAX rule more. So 66% of the patients had been triaged with the TMAX rule, whereas North Manchester Hospital had only 8% of the patients on which TMAX was used, and Wythenshawe, the TMAX rule was still not being used. And now we'll see how this has impacted on the admissions and length of stay. So MRI, which had been using 66% compliance with TMAX, had the least number of admissions, 44%, and even the average length of stay per patient was quite low, 1.8 to 5 days. North Manchester had a 75% admission rate, and Videnshaw had 79% admission rate, which falls in line with the TMAX compliance. Average length of stay should be taken with a pinch of salt because these three hospitals are different setups with different hospital dynamics. So even if we reduce the admission percentage with the use of Tmax, the average length of stay, although it will decline, but it may not go low to the same proportion as MRI hospital or any other tertiary care center. According to as per the results of the audit, as per the compliance to standards, we give them an RAG rating. And because each hospital had less than 75% compliance, the overall RAG rating for this audit was red. And because all the compliance standards were red, so using these RAG ratings, we calculated an assurance level which was very limited for this particular audit. So our conclusion from this audit was, because TMAX is a very important tool, and it highlighted the importance of some training sessions, refresher courses for all the doctors to familiarize them with the usage of this tool. And we have seen that as the compliance with the TMAX rule will increase, we expect that the admission percentage to go down, and similarly the length of stay for patients in hospital to go down as well. Yeah, that was from me. Thank you. Any questions?
Brilliant. Thank you so much. And actually, having just heard a little bit about clinical decision aids in ACS from Lee in the session just before yours, it's really interesting to hear about how TMAX has been used in your department. I have one question for you, if I may, which is, what are the next steps for you guys in this piece of work?
So the next step in will be looking at the challenges in implementing TMAX, because different hospitals have had different limitations when we talk about implementing TMAX, and the number one thing has been resistance from the other specialties, especially cardiology, because not all hospitals have the resources to get patients either directly admitted to cardiology at all time, or many hospitals don't have the ACU or the CDU facility, especially in ED area, where most people in ED keep their patients to for a repeat 3-hour troponin. So there has been resistance from different specialties and resource limitations, which we are trying to find out by working in collaboration with the leads from different specialties in different hospitals. But I think a wider spread of the actual efficiency of TMAX needs to be there, so that everybody can realize the importance, and we can help save more resources in the long term.
Brilliant, thank you. There are a couple of other questions in the chat for you as well. So one of those is, what scoring tool were the other trusts using?
Mostly the scores that have been initially been used have been MACS rule, have been Heart score, which have been used, but they're mostly they are good as well. But I think once we have evidence for a superior tool, now it's time to shift on to a more superior tool. Obviously, this is a tool that will help your decision making. It's not like you have to go entirely by TMAX. If there are sometimes patients which you would like to keep admitted to the hospital, even though the TMAX may say it's a low risk due to your clinical reasoning or whatever. It's ultimately a decision making rule. So other hospitals have been using MACS, they have been using Heart, but I think TMAX has been proven to be a superior one now, and it's time to move on.
Thank you. And there is another question for you, which is about atypical presentations for ACS. So obviously, we've just been talking about patients that presented with chest pain, but were there any other sort of angina equivalent presentations that were taken into consideration?
No, maybe I think when the researchers were finding out about the TMAX tool and how what is the degree of sensitivity and what degree of how they calculated the negative predictive value. I think it may have been taken into account, but I'm not sure. But as far as this audit is concerned, we didn't take into account the atypical presentations. We just took into account the patients who present to hospital with cardiac pain, where the ED clinician would think ACS as one of the primary differentials, and would decide on whether this patient can go home or whether we need to be admitted based on that. Atypical presentations were not included. Any complaint other than a cardiac chest pain were not included in this audit.
Thank you. And were you able to get any data about patients who may have been labelled as being low risk and discharged, but who subsequently returned to the ED with ACS?
No, so this audit was a retrospective data just collected on the basis of data from the hospital, that which patients were admitted, which patients were discharged. We did not follow up the patients who were discharged as to whether they represented and with what complaints that they represent. Obviously, we had seen while collecting data some patients representing again with angina, again being sent back, but such data hasn't been recorded in our audit, so I cannot give you any statistics on that. But what I saw when the patients represented was the patients represented with angina, but they were being kept sending back because they didn't have an ACS diagnosis, and the chest pain was generally related to some other alternate diagnosis.
Thank you. And I have one more question for you before we let you rest. So there is a comment that says it seems to be a good tool to decide about admission, but how would it affect the length of stay for patients, or would it affect the length of stay?
So if the patients are not being admitted, and if we are doing a repeat troponin within 3 hours in ED itself, one, it sends the patient home early. Secondly, it avoids the patient being sent over to refer to acute medicine when the patient would be clogged, would be post taken by a consultant at some point, whether at night or in the morning, or may await in the hospital for a cardiology consultation, which can further delay the patient stay. So overall, if the patient is using TMAX is sent early within 3 hours, it limits the patient's length of stay to 3 hours in hospital. But if the patient for whatever reason is kept in hospital, even if the patient is a low risk patient, and then awaits all these things as I mentioned, it could increase the stay to maybe 24 hours or even more. So even for per patient, we are conserving a lot of time as well as hospital beds using this TMAX tool.